Hello, everybody, and welcome back. This is lesson 3 of module 3 on the reciprocal relationship between society, healthcare, and aging. In the first lesson, we defined lifespan and healthspan. In the second lesson, we talked about the social determinants of health with a specific case study on the gender gap in healthspan and lifespan and its determinants. Today, we are moving forward to the reciprocal relationship between healthcare and aging. And then we will move on to a case study on the relationship between healthcare systems and life expectancy in the US. Thank you again for joining us. Let's start by acknowledging the reality that we are all aware of. Our population is aging. This is a result of advancements in healthcare, lifestyle changes, and overall societal progress. However, as the percentage of older individuals increases, we begin to see escalating demands on our healthcare systems, increasing the strain on resources and manpower. The healthcare system, originally designed to cater to a balanced demographic, now faces the challenges of adapting to serve an older population. So we're talking about increased hospital admissions, more prescription medications, more chronic disease management, and more specialized care. In short, the healthcare system is under a growing burden. But let's not forget, this is the very efficacy of our healthcare systems that has enabled this longevity. The success of public health initiatives, advancements in medical science, and early interventions have all contributed to extending lifespans. While this is undoubtedly a triumph, it creates a cycle. Better healthcare leads to longer lives, which in turn leads to an older population, subsequently placing greater demands back on the healthcare system. Lastly, society plays a role here too. Social determinants of health, as we discussed in the second lesson, can ease or exacerbate these healthcare demands. So the conversation also extends to societal advancements, public policy, and even urban planning, all of which must evolve to meet the needs of an older population. Moving on from our discussion of the interplay between healthcare, aging, and society, let's take a moment to delve into the bedrock of healthcare systems. Understanding the foundational principles give us context to better appreciate the challenges we face. First and foremost, the cornerstone of any healthcare system is to provide a basic minimum level of healthcare for all individuals. This is not a luxury. It's a fundamental human right. The goal is universal healthcare access. Whether you're young or old, rich or poor, the system is designed to serve you. Secondly, healthcare systems serve as epicenters for the generation of scientific knowledge. Through research, trials, and case studies, our understanding of health and disease is continuously expanding. Lastly, healthcare systems aim to reduce health inequities. The goal is to level the playing field, addressing disparities related to socioeconomic status, gender, ethnicity, and geographical location. However, it's critical to recognize that healthcare systems are not all powerful entities. They have their limitations. While they strive to meet these foundational objectives, the reality is that resources are finite. Whether it's personnel, equipment, funding, or time, constraints exist. But let's understand that our healthcare systems are not adequately optimized to serve the unique health needs of older people. Firstly, our healthcare systems are not adequately optimized to handle the unique medical needs of older people. This includes everything from the design of healthcare facilities to the kind of treatments and medications that are emphasized. Secondly, we face the issue of an inadequately prepared healthcare workforce. Despite the growing number of elderly people, many healthcare professionals do not have a specialized training in geriatric care. The rising elder population has led to an increased need for dependent care, such as assisted living or in-home care services, as well as specialized personnel trained in managing age-related conditions. Yes, these areas remain under-prioritized and under-resourced. While living longer is something to celebrate, longevity often brings a host of chronic illnesses and health issues. Our healthcare systems must be prepared to manage these complexities rather than merely focusing on acute care scenarios. And finally, we have to address the elephants in the room: barriers to care and age discrimination. The elderly often face systemic barriers, including high cost and lack of access to necessary medications. Also, age discrimination can further hinder the quality and availability of healthcare services for older individuals. Let's shift our focus from the challenges faced by the elderly in healthcare to explore the different types of healthcare systems that exist around the world. Understanding these systems is crucial, as the type of system in place can significantly impact how these challenges are managed in terms of population aging. In general, there are four major types of healthcare systems around the world. Let's start with the Beveridge model, named after the British social reformer William Beveridge. This model is characterized by healthcare services that are provided and financed by the government through tax payments. In countries like the UK, this leads to what is commonly known as the socialized medicine. The pros of the Beveridge model are a universal coverage and actually lower costs. At the same time, the cons are that this system may suffer from inefficiencies and longer waiting times for elective procedures. Next up is the Bismarck model, named after the Prussian Chancellor Otto von Bismarck. This system, as seen as countries like Germany and Japan, consists of healthcare financed through tightly regulated private sector insurance plans. Everyone pays into a sickness fund, which in turn covers their medical expenses. The pros of the Bismarckian model are high quality care and generally more choices for patients. At the same time, this model can be quite expensive and complicated to manage. Let's move on now to the mixed model. The mixed model is exactly what it sounds like, a mix. Countries like Canada utilize a blend of different elements from both Beveridge and Bismarck. Government-run healthcare exists alongside private options, giving citizens a choice. The pros of the mixed model is that it offers both choice and comprehensive coverage. At the same time, the cons are balancing both systems can lead to inequalities in access and quality of care. Lastly, we have the out-of-pocket model. In many low-income countries, like in India, structured healthcare system may be minimal or non-existent. Individuals are often required to pay for medical services out of pocket, leading to significant barriers to access to care. The pros of this system is that immediate payment can sometimes lead to immediate service. However, with the out-of-pocket model, there's high risk of healthcare inequality, often leads to catastrophic financial burden. Now, let's try to understand what are the implications of each one of these models for elderly care, Or put it differently, what is the effect of population aging on each one of these healthcare types? In the privilege model system like the UK's NHS, an aging population poses unique challenges due to the increase in demand for chronic disease management and long-term care. These systems are generally well suited for universal coverage, but may struggle with resource allocation as the elderly population grows. All-inclusive care can be advantageous for the elderly who have multiple health issues, but at the same time, the strain on the system can lead to longer waiting times, especially for specialized care. Let's move on to the Bismarck model. And in countries like Germany, an aging population puts financial stress on the insurance-based system. As older populations retire, fewer working-age individuals are paying into the sickness funds, which could eventually result in higher premiums. So on one hand, high-quality specialized care is often available for chronic conditions common in old age. But at the same time, the financial sustainability of the system can be threatened by a large aging population. What about the mixed model? For mixed model systems such as those in Australia and Canada, the impact of the aging population is a bit of a mixed bag. On the one hand, public systems could face similar strains to the Beveridge model, and on the other hand, the private system might encounter sustainability issues similar to the Bismarck model. The mixed model can provide choice for elderly individuals who can afford private care. However, risk of inequities in care quality and access can become more pronounced for the aging population. Lastly, let's move on to the out-of-pocket model. In countries with an out-of-pocket model, naturally, an aging population is particularly vulnerable due to the absence of a safety net. The cost burden of healthcare falls directly onto the individual or the family, what we call the individualization of risk, often leading to catastrophic expenses in old age. So, on one hand, immediate service is sometimes available for those who can afford it. However, elderly individuals who cannot afford care are left with little to no options, exacerbating healthcare inequities. In summary, what can we learn from the effect of aging on healthcare systems and healthcare systems in general? Each healthcare system type has its own set of challenges and advantages when it comes to serving an aging population. As the demographic shifts continue, each system will need to adapt and evolve to ensure that the healthcare needs of older individuals are adequately met. So thank you for sticking with us, and see you soon in the case study on the unique relationship between healthcare and longevity in the US.